I'm going to unshare the screen so people can see you up close. And here we go. The first question we have is about how do you feel about hydronic acid injections?
Okay, so that is the Visco supplement injection that we touched on earlier. And how I feel about it is I'm actually kind of wish that they didn't stop paying for it. Because I think that it was a very effective tool in certain patients that I wish we still had available to us. It's nice that we can still use it in Medicare patients, and I do have some patients that do choose to pay for it. And as I said earlier, the insurance companies will usually pay for the injection as long as you pay for the medication. It's not for everybody. There are certain times where, I mean, if you're already in your late 60s or 70s and the joint is genuinely worn out, I agree with the insurance companies. It's like, what's the point? Is it really cost effective? Is it just delaying the inevitable? And the answer is yes. And the results of the surgery are usually so tremendous that, you know, people will look back on it and go, why did I mess around with all that other stuff when I could have had this? Because this is great, you know. But there really are certain patients where we want to get them going longer, or maybe it's just not the right time for patients. They have family issues and things going on, where maybe they're a caregiver and they just can't be encumbered with a knee replacement right now. And it is something that can buy them time. So good thing to have a conversation with your surgeon about and kind of consider your own personal situation. And sometimes we can even pull strings with that information to get the insurance companies to authorize them for special circumstances.
Great. Our next question is, any ideas for an adductor that has never just healed for years? I have an injury injured going for a tennis ball, tender from near the knee all the way into the groin. I've had PT and still a problem. Any recommendations?
Okay, that's a little bit more of a difficult question to answer without really taking a thorough history and having the ability to examine it and then maybe get appropriate studies such as MRIs and stuff. If your question is a knee replacement the answer for that? It may not be if you're still having problems with a muscle tear. The question is where is the pain really coming from? Sometimes the problem can be at the muscle attachment, or it can be at the musculotendinous junction, which is mostly the case, and just replacing the knee itself may not be the answer. But if the arthritis in your knee is causing your knee to be in an alignment that is putting unnecessary stress or abnormal stress on that adductor that may be preventing it from healing and thereby balancing out the knee and stabilizing it, may actually improve the adductor healing. But it's something that would really need a little bit more history and inspection and physical examination to be able to fully answer that.
Thank you, Dr. McDermott. And I just also want to remind people that they can still ask questions by scrolling their mouse over and clicking on the Q&A button and typing in their questions. We do have a bunch of questions, so let's go. Next question is, why do you not recommend ibuprofen?
Well, I didn't say I don't recommend it. I'm just saying that you have to use it judiciously. Number one, you need to make sure there's no contraindications to using it. I think you lump ibuprofen and naproxen in the same categories, or Aleve, the naproxen sodium. All of these are non-steroidal anti-inflammatories. They are metabolized in the kidney. So if somebody already has ongoing compromised kidney function or decreased kidney function, or they have a history of ulcers or stomach bleeds or gastric bleeding, it may not be the right thing for them because it actually aggravate those situations. And again, there's a big difference between short-term use of medications and long-term use of medications that if ibuprofen is working, that's great, but you really do need to monitor patients at their yearly physical for whether or not there's any silent compromise or damage that's being done, which can sometimes be brought out on laboratory studies or if you're, of age where you're getting routine colonoscopies or upper endoscopies, you may see, irritation or damage or bleeding that's going on. So it just has to be tracked, and it's like anything else. It's at a point where if you're just going up on the dosage, then there's probably something else that needs to be done. Maybe it's another drug. Maybe it's using, start using glucosamine if you're not already, or using the injections, and so it's everything in the bag of tricks and kind of using it all until that's no longer effective. But I don't think I ever said that I'm against it. I actually use it a lot in my practice.
Thank you. Next question is, how can I tell the difference between sciatica in your hip or buttocks and actual hip joint pain?
That's a really good question. Sometimes they can present themselves very closely. The hip pain most of the time will present itself as pain in the anterior groin, so in the front of your hip, whereas sciatica is usually a posterior problem and in the back. Sciatica, people can get something called sacroiliitis, where the pelvis attaches to the sacrum, the sacroiliac joint can be a little bit out, we say, to where it has to be kind of reduced back in, and that can produce pain in the posterior aspect of the hip that can mimic hip pain. Sciatica will also oftentimes produce pain that shoots down the leg into the posterior aspect of the leg and go down to the ankle or the foot, and hip pain will usually not do that. So if there's any question, and then also if you have sciatica, it may limit your hip range of motion, but if it does, it's because of pain, whereas hip arthritis can limit range of motion from pain, but when it gets very advanced, it actually will limit it just because it mechanically will obstruct it. And you can tell that because it just won't go any farther. If you try to force it, it really hurts. So if you're having pain that's what you think is sciatic, or whether it's hip and it's not responding to over-the-counter remedies, then the best thing to do is just come in and be evaluated. And then the other thing that we'll do is, after taking a history and deciding whether we think it's based on what you're telling us, whether it's more hip or back, then we'll also obtain appropriate x-rays, and usually you'll see the pathology.
Thank you. The next question is, I have osteopenia. Would my bones be strong enough for a knee replacement?
In most cases, yes. It's if it was really bad, if you were a rheumatoid, or depending upon certain medications that you've been on, you may need a bone density study so we can see just how osteopenic you are. It's not a contraindication to doing surgery, but it may be a situation where we use revision components that have longer stems on them so that it incorporates more bone in the stability process, so that you're not overstressing the soft bone, which can cause the implant to fail or collapse.
Thank you. Next question is, does congenital hip dysplasia cause arthritis in the hip, and would it cause the need for a hip replacement later in life, like around 67 years old?
Yes and yes, and sometimes even earlier, even sooner, depending upon the extent of the dysplasia. So we see that a lot. It can produce a tremendous amount of arthritis too, where sometimes the surgery for the dysplastic hip can even be more difficult than some of the primary osteoarthritis hips.
Right.
Usually there's also a distortion of the anatomy, but that all gets corrected at the time of surgery. So it's not a reason not to do it. And those patients are usually pretty happy.
I think you may have addressed this one, but we'll ask it anyway. How many times can I have a cortisone injection if they seem to keep me comfortable for 3 months or more? Is there a limit to this therapy?
Yeah, and the answer again is there really is a limit. Fortunately, what happens is the honeymoon period tends to shorten as you've had more and more injections. They just become less and less effective. But if you start, again, we talked about that there's no hard number on how many, but the more injections you've had before surgery increases the risk of developing an infection afterward, which is something that you will wish never happened. And you're, again, prolonging the inevitable, when you get to the point where you need a hip replacement, usually the results of the hip replacement far exceed the results of the injection. So you kind of have to weigh that out patient to patient. But, you know, I've turned away patients that have come in and told me they've already had 25 injections in each knee. And I'm saying that's too much. It's enough.
All right, next question. With coronavirus, are you doing surgeries now? And if I have surgery, how sure can I be that I won't catch coronavirus in the hospital?
The answer is yes. We did discontinue surgery when coronavirus first came out, and it was limited to trauma or urgent cases and semi-urgent cases only. So we did do some cases in the surgery center. Somebody had a meniscus that was a big tear that was flipped and their knee was locked. You can't ask that person to go 5 or 6 weeks and not have surgery when they can't even straighten their knee. So we did semi-urgent elective surgery, but we did stop knee replacement for, I think it was about 4 or 5 weeks. And then as we started finding out more about the disease and whether it was going to spread more rapidly than it did, were we going to have enough beds available in the hospital, because knee and hip replacement do require overnight stays in most cases. Then we started opening it up, and we did so with selected cases to where we started with the younger patients, those that were less susceptible to the virus first, and to see how things were going to go. And we have been doing it now since, I believe, the middle of April, and or maybe the end of April. And to my knowledge, I don't know a single patient that's contacted COVID because of it. Most of the data that we have on this comes out of New York. It was the initial data that came when they were having all these patients on ventilators and seeing a lot of deaths and trying to decide what effect did it have in terms of who came off ventilators and who didn't. And what we do know is, yes, there is coronavirus in Sonoma County. And yes, there are COVID-19 patients in every one of the hospitals here, whether it's Memorial, Sutter, Healdsburg, Kaiser. And yes, there are some patients in the ICU. Those patients are all in isolation. None of them are on the same floor that the patients will be after knee replacement or hip replacement surgery, or any non-COVID patient. And again, it's one of those things where this has done more to convince patients that they don't need to be in the hospital 2 or 3 days after surgery than anything that we've been able to preach for years, because we tell them, look, you don't need to be here any longer than necessary. And they're more than ready to go home the next day and coming back saying, man, that was great, you know? So we try to do these surgeries with local anesthesia, like in regional anesthesia, spinals and adductor canal blocks and posterior capsular blocks, and usually conscious sedation. If general anesthesia is used, it can be done by mask or even through something called an LMA, like a diaphragm. There's some data, but it's limited, so it doesn't really have a lot of power, but that anybody that's been intubated is considered to be more at risk if they were to come in contact with somebody that had COVID, you know, in the short term after surgery, 4 weeks, that they would be more susceptible to catching it than had they not recently been intubated for surgery. And if they did catch it, there'd be a 40% chance that they could be on a ventilator, and 20% of those people there was mortality in 20% of those people that went on the ventilator that never came off of it. But again, this is still very, very, very limited data that came in the first few weeks of the patients in New York, and it really needs more study. You know, for that reason, we've been pretty conservative with it, and there's when people have to go to the operating room, we have designated COVID rooms that are not used for elective surgery. So lots and lots of precautions are being taken, and people are doing very well. But certainly something to consider. I mean, if you're an elderly patient, which a lot of knee replacements are, and hip replacements, and depending upon your overall health, if your knee's not bothering you that bad, then maybe it is something that you want to wait on. The problem is we just don't know how long this is gonna go on. So you could change your mind at any time, and as we learn more about it, then we'll be able to make more and more recommendations. But it is considered to be very safe. We haven't seen a single case of anybody coming down with COVID or having any complications from it since we started up with the knee replacement and hip replacement again.
All right, thank you, Dr. McDermott. We have about 30 more questions, so I'm going to ask you to shorten them up, the answers a little bit.
Okay.
So the next question is, I've been taking a probiotic with Bifidobacterium infantis, supposedly good for joints. Are you familiar with this?
I'm familiar with some probiotics. Not that one in particular. Again, you'd have to look at it, and I'd have to pull out the package insert and find out what they had in there and why that was supposedly good for joints. But, remember, there's a lot of things they say are good for joints, and it sells well, but the scientific data oftentimes is lacking. So you really look at that from the standpoint of what's the harm in taking it other than maybe cost, and if there's no side effects, give it a try. If it works for you, great.
Great. Next question is Kevlar artificial cartilage available?
That's not really at a point yet where it's universally available, and again, you're going to have a real hard time getting insurance companies to cover that one.
All right, thank you. The next question is, have you ever experienced blisters on the incision weeks after surgery?
Well, you certainly can. Again, there's a lot of things that you need to do to prevent that. Find out, number one, does anybody have any allergies to adhesives? And if you're putting adhesive dressings on there, that's usually what causes blistering most often. You can also get it. It depends on your technique and how well you control your bleeding after surgery, because this is why sometimes I say that the length of the surgery is sort of less important than the quality of the surgery. Take a little bit more time to control your bleeding on the way out, and make sure that the knee is dry. If you get a lot of bleeding in there, it leads to a lot of swelling. That's going to cause tissue edema, and that will lead to blisters. And of course, the problem with that is now you've broken down your skin barrier and you're more susceptible to picking up an infection. So good closure techniques. I do a multi-layer closure. Most of the time when I take my dressings off the next day, they're bone dry.
Great, thank you. Next question is, will I be able to kneel on my knee after knee replacement?
So you certainly can. It's not recommended, and patients usually figure that out on their own. And the reason I say that is because, remember, your cartilage is gone. You no longer have any cushion or shock absorber. For the same reason why it's not comfortable to run on it, you now put a plastic button on the back of your kneecap, which is bone. And now you're kneeling on that, and it's coming in contact with metal on the other side, and there's absolutely no give. So in most cases, it really feels like you're kneeling on a rock. And it also, if you take any item that's plastic and you put a piece of metal against it and rub it on that, no matter how polished it is, over time, it tends to damage the plastic, and you really don't want to do that to a knee that you want to have last for 25 or 30 years. So that's one of those areas where we really tell people to try not to kneel on your new knees, whether it's painful or not.
Great, thank you. The next question is, I hurt my knee in 1975 by a fall on a bent leg, recovered, but the back of the knee feels lax and created a popliteal cyst. Never had much swelling, but now feels full. Had meniscus surgery in 1999, which did not do much. I'm an active senior. When do you repair a posterior cruciate ligament?
Usually with younger patients, I guess, and that's not the only indication, but if you're already an active senior, and if your problem isn't instability, then again, it's one of those where it'd be nice to sit down and discuss that one in person with a little bit more information, even though you've given quite a bit. People can function well with a posterior cruciate ligament rupture, whereas an anterior cruciate ligament rupture in most cases have to be reconstructed. I do posterior cruciate ligament reconstruction. It's amazing how many people can function without it. It can lead to arthritis in the knee because of the abnormal motion, but it can also lead to meniscal tears. But I would imagine if this has been in that knee for that amount of time, that there's probably also arthritic changes in that knee or degenerative changes in the cartilage. And it's probably a situation where the knee replacement is the more appropriate option, because that will correct both the meniscal tears and the cartilage damage, as well as the posterior ligament rupture. But that's something we could discuss.
Okay, next question is, what daily dosage of turmeric do you recommend?
What you want to do is just pick that up at the local pharmacy, and then just kind of start with the low dose. And again, you just kind of want to be cautious about increasing it. If it's working, it's working. If it's not, if you have to keep going up on the dose, then it's maybe time to try something else.
All right, thank you. The next question is, aside from Sutter, are there any other Sonoma County hospitals doing the same day discharge to home after a total knee arthroscopy? I have treated one patient of Dr. Howe's that was an AM surgery with a 7 p.m. discharge to home this past January at Sutter.
Yeah, I mean, it's really all the things we talked about in terms of the anesthesia, the post-op care, the nursing care and stuff contribute to it in terms of when the patient goes home. And it also has to do with the surgeon's comfort level and how the patient's age and how well they're doing. And that happens at Memorial too. And I'm not doing any replacements at Healdsburg, but again, I think that it's really surgeon dependent. Both Memorial and Sutter have these programs, and that's what's so good about it, that it gets us all on the same page from all elements, the post-op rehabilitation team as well as the surgeons. And that's what really gets people out the door, safely.
All right, our next question is, after sitting for a short amount of time, 15 minutes, when I get up, my right hip has an ache, and after a few minutes of walking, all is well. Is this a sign I should see a doctor?
Yeah, that's classic arthritis. It could be other things, but that's what arthritis does. It likes motion. It doesn't like immobility, but then it reaches a point where too much motion becomes symptomatic, and that's usually when you have to do something else. But that's what happens. And it's amazing how bad the arthritis can get before people start having symptoms or complain about it, because the process is so gradual that traumatic situations, people that have actually had arthritis from traumatic situations tend to tolerate it less than those that had just degenerative arthritis. But that's what's describing. Initially, it does actually feel better to loosen up the joint and get it lubricated. And I would go see a doctor about it and get x-rays so it can be quantitated, and then talk about a long range plan while there's still more options.
Great. Next question is, I have lots of knee pain walking downstairs. No problem going up or easy walking. Any idea of what could be going on?
Well, with that limited information, a whole host of things. It could be a meniscal tear. It could be patellar tendonitis. It could be arthritis of the knee. But it is typical that usually going downstairs is more difficult than going up. And you would think that it's harder going up because of the push off, but it's the need to decelerate the knee when you're stepping down without it giving way tends to make going down more difficult. But I really couldn't put a diagnosis on that without more information, x-rays, and an examination.
Great. Next question is general anesthesia okay for patients that have recovered from a stroke?
That's a really good question. And in some cases, yes. But it is something that is, if regional anesthetics and local anesthetics can be done, it's better. So again, that really depends on how bad the stroke was. and now you're getting into the anesthesiologist's kitchen, and that's kind of one of those things where we definitely talk about those things, and it's not that it can't be done, but I will then usually get a hold of the anesthesiologist and see if they want to do a consultation on that patient before the surgery and it becomes their kitchen to decide what's most appropriate.
Great, thank you. Next question is, can I ride a mountain bike before and after knee replacement as long as it does not hurt?
Yes. Yeah.
Great.
Again, it's a little bit more pounding, but again, it's low impact and it's lubricating. You know, you need to decide how aggressive you want to ride, because remember, if you get thrown from the bike, this is when you start getting into situations where you could have a fracture, and it oftentimes will occur around that prosthesis. And so that becomes a more difficult situation in terms of you're trying to repair a fracture and deciding whether you need to remove the previous joint components and then put them back in with plates or rods and things like that. So riding too aggressively on trails that you're unfamiliar with may not be such a good idea, but there's no problem riding a mountain bike.
All right, thank you. Next question is, will visco supplementation increase infection with knee replacement?
Hard to say from let's talk about it. The data is mostly on cortisone injections, because what cortisone does is it reduces an inflammatory response, or and an inflammatory response is exactly how your body fights infection. So you're compromising the body's ability to fight an infection. But just the act of introducing a needle into the knee is a sterile environment. And even though we clean the knee with chlorhexidine preparations or betadine, and the needles are all sterile, it's probably not completely sterile, but the amount of bacteria that gets introduced with each injection is minuscule. But if that becomes additive based on the number of injections that you've had, when we talk about limiting the number of injections you've had before surgery, we do throw the visco supplement injections in there. We're certainly a little bit more cautious when more of them have been cortisone, but it usually gets to a point where those are just no longer effective anymore, and the patient is more than ready to move on to knee replacement.
Great. Next question is, my bike seat was lowered, causing my leg to be bent too much when riding. My knee doesn't hurt at all, except for when going upstairs or uphill. It never swelled or became inflamed. What could this be?
Well, raise the seat height for one. You could be onto something where you're simply going into too deep a flexion, and that increases the contact stress on the patellofemoral joint, and that can happen in a totally normal knee. You could have meniscus tears, you could have early arthritis, again, all the principles that we've talked about already, you really need to apply those. And I think you're already onto something with the knee flexion angle. When you're climbing, you want those first 30 degrees of flexion. You don't want to get down to like 60 to 90 degrees.
Next question is, why do hips ache so much when we lay down in bed at night, but not getting up? It's so bad sometimes that it wakes me up from a dead sleep.
Well, there may be a couple of things going on, or one thing or the other. That may be a function of arthritis, but it could be something just like known as trochanteric bursitis, where I think you can all reach down and feel the side of your hip and there's a bone there. And if you put your hand over that bone and get up from a chair, you can feel how tightly the band over it puts pressure over that bone. And there's a bursa under that can get inflamed very commonly, which is usually treated successfully with cortisone and physical therapy, one or the other or both. But you can also do it with arthritis. If you have an arthritic hip and you're laying on that side, you're creating more pressure of the ball up against the socket while you're laying on it. And it's like we talked about earlier, where you stay in one position for a long period of time, like driving in a car with a knee or a hip, and it gets stiff. So that extra pressure when you're laying on it will cause that much more inflammation and pain sooner, and maybe to a greater extent to where it wakes you up.
This is kind of another question in the same vein. It says, what if you have hip pain? What if you have pain in the hips that keeps you up at night, been going on for months? and sometimes there is an experience of collapse of the hip, but no diagnosed arthritis.
So was, when you say no diagnosed arthritis, is that because there was x-rays that were performed and showed no arthritis? If that were the case, then I would look for other sources. Maybe there's a labral tear in there if people are getting popping sensations, or even if they're not, that could be causing the pain. Again, it could be trochanteric bursitis. It could be a tendonitis or inflammation of any of the muscles that are surrounding the hip joint. So again, this is very little information to make a diagnosis, where not only is more information necessary, but the ability to not only also look at x-rays, but examine the body. That's going to give you a lot of information that's going to help you nail that diagnosis down, so that accurate recommendations can be made.
Next question is, how long before you can use your leg for weight-bearing walking?
After a hip or knee replacement?
I'm assuming that's what it is, but it's not specific here.
The day of surgery, we get you up. You know, we don't want you in bed. You can put full weight on these components. They will not fall apart or come out or loosen or dislocate. And you usually, patients will tell you that, you know, yeah, I can feel incisional pain, or if it's immediately after surgery while the blocks and things are working, maybe none at all. And all their arthritic pain is already gone. So yeah, you get up on them right away.
Good. This is an interesting one. Since the relationship between tissue pathology and pain is not good, and many people function well despite pathology with little to no pain, would you consider using interdisciplinary pain management as another conservative treatment method?
Say that one again, Sean.
Sure. Since the relationship between tissue pathology and pain is not good, and many people function well despite pathology with little to no pain, would you consider using interdisciplinary pain management as another conservative treatment approach?
Yeah, I mean, certainly I'm not opposed to alternative medicines and things like that. Again, you're describing a patient that's been maybe diagnosed with arthritis, but saying they're not having any pain, if I understand that correctly. You just have to apply the treatment to the individual. And again, it's a matter of bringing a patient into the office, having a conversation with them, and really going through, taking a thorough, comprehensive history, looking at x-rays, and then and then listen to what the patient's saying. Where are my symptoms? What brings them on? Am I having pain? Am I not? What have I done for it? And then you have to take all that information into consideration. How old is that patient? What treatment options are available? You know, again, if they're young and you know that knee probably won't last 25 or 30 years, because maybe they're still working and they're going to put a higher demand on it, and you want to try to put that off as long as possible. All that factors into it, but I don't rule out alternative sources of medicine by any means. I think those can be just as effective. I mean, you're getting into things like acupuncture, certainly. And again, I've said I'm a very big believer in that.
All right, next question is, what do you do for fluid on the knee? My husband has had it removed twice and some cortisone injected. He doesn't have much pain, but his knee filled up with fluid after each draining.
So the fluid is an indication that there is some pathology in that knee. Probably arthritis, probably possibly a meniscus tear as well. And that's what, you get sand in your eye waters and produces tears, right? If you get irritation in your knee in the form of cartilage wearing out or becoming degenerative, it will produce reactive fluid. And it gets to the point where the knee will swell up so bad that it can, if it doesn't cause pain, it can shut your quad down and it can compromise your range of motion, which can then lead to episodes of giving way or pain. So tapping the knee and removing fluid from it is the right thing to do, and following it up with a cortisone injection is to reduce the inflammation to prevent it from coming back. But again, this counts as a needle that's been in the knee, you know, so every time you introduce a needle in there, you could introduce an infection. I think it's a very reasonable thing to do. and I do it in my practice to aspirate knees and inject them with cortisone. But if it keeps happening, you really have to explore why is that happening, whether it's an MRI that tells you have a meniscus tear. At that point, you probably need to do something about the meniscus tear. Same thing with the arthritis. I mean, then you start having to look for, has physical therapy been done? Is this one of the reasons why maybe you find out that the arthritis is just so advanced that this may be another reason why they just simply need to have the knee replacement done.
Great, thank you. Next one is, a doctor performed my right THR 4 years ago. Very happy I did. Recently, I have strained lifting something heavy walking up steps. Can ligaments / tendons get strained?
Sure they can. Yeah, the same way they could before the hip was replaced. Again, even conditioned athletes, if they're out of shape for a while and they don't condition and they go back to their sport, then they're more susceptible to injuring muscles and tendons at the attachment as well as at the musculotendinous junction. And what are we dealing with in a situation with a hip replacement? Well, usually somebody's activity level became more and more compromised until they finally had the hip replaced, but at the same time they were less active, so those muscles got out of shape. That's why preoperative physical therapy, whether it's a knee or a hip, is very, very important and can pay dividends from the standpoint of restoring that strength before the surgery to pay dividends afterward. But absolutely, that can make people more susceptible to muscle strains and tendonitis.
Thank you. Next question is, after an ORIF surgery, is it common to experience pain in adductor muscles such that it prohibits weight bearing on that leg?
That's another one that's a little bit difficult to answer. Your pain can be coming from a number of sources, injury to the muscle. Maybe it's the hardware that's in place that is causing it. But oftentimes, as we mentioned earlier, it can be that for a period of time after a fracture like that, we try to get you up as quickly as possible and get you moving again, but muscles get weaker far quicker than they get strong again. And so it could simply represent a strain. That's one where I would, have to look at the x-rays and take a look. Is the hardware in a position where it could be causing irritation, or is this simply a matter of just needing get somebody in some good physical therapy and work it out and strengthen it?
Great. Next question is, I had a knee replacement a year ago. One of the complications I had was I got a pinched nerve in my lower back, either during or after the surgery, and had a lot of nerve pain in my leg. Is there a way to avoid this, because I'm going to need to have my other knee done?
Well, my recommendation would be that before doing the knee, that the back be worked up thoroughly with x-rays, physical examination. The nerve probably didn't get pinched just by the positioning. There's probably some degenerative changes in that lower back that got inflamed or aggravated as a result of the surgery, whether it was from being asleep on a table for an hour to 3 hours, or leaning over, utilizing a walker after the surgery, bad posture, decreased back strength, that type of thing. And in those cases, oftentimes I will treat the back first, depending upon the extent of degenerative changes there, and kind of decide which one's the bigger problem. You might want to send somebody for selected facet joint injections or epidural steroid injections and things like that, and physical therapy for back strengthening and rehabilitation to get the back optimized before approaching the knee. So it's a coordinated effort.
Okay, next question is, if you need a knee replacement and then lose weight, could it possibly reverse the need for the replacement?
Yeah, absolutely it can. I've seen it often. That's the biggest thing is the American Academy of Orthopedic Surgery came out and said anybody whose body mass index is above 35 should be considered a relative contraindication to knee replacement, and over 40 should be considered for possibly to be an absolute contraindication until the weight comes down. And there's a number of reasons for that, because there's usually a bigger soft tissue envelope that can produce rolls in the skin that can trap bacteria near the incision after the surgery and lead to infection. But also just trying to carry that weight around when you already have muscles that have lost strength can lead to increased falls and things like that. But you get into that 1=5 formula again, and I've seen a number of patients that some people, this is not just, I think people are cruel to people that are overweight, and they think that it's all behavioral and relative to overeating, but a lot of times it is metabolic. And so sometimes the surgical options become a consideration, and you see people drop 50 pounds and they'll come back and tell you, my knee doesn't hurt anymore. I'll come back and see you when it does.
All right, next question was, what's your experience with cannabis oil? Does it work? Question mark.
I see an awful lot of patients coming into clinic that swear by it. So, it's something that so far I haven't seen anything in the literature or otherwise that has shown any adverse properties or with using it. It's a topical, it's over the counter, and I've seen a lot of patients, particularly with soft tissue stuff and in arthritic cases, that really swear that it helps a tremendous amount.
Great. Just a couple more questions. Next one is, can a nerve issue in the foot happen because of a meniscus tear?
Can a nerve issue in the foot happen because of a meniscus tear? I would say probably not. Okay. Unless that meniscus tear was causing pain in the knee, which was causing somebody to walk differently, to where they were placing weight on the foot in a manner that was out of balance with their anatomy, then yeah, it could certainly do that.
Great. Next question is, when can you drive again and resume normal activities after a knee replacement?
This is the great question. So the legal answer from all my attorney friends is to, as a physician, to never give someone permission to drive after surgery, because if they get in an accident, then the attorneys will want to go after the surgeon that gave them permission too. The rule of thumb is this: you can drive when you can safely control your vehicle in an emergency situation. If a young child ran out in front of your car and you had knee surgery on your right knee, and the minute you stamped on the brake pedal, you had pain that was severe enough to cause you to reflexively pull your foot off the brake, then you should not have been behind the wheel. If you're under the influence of any post-operative pain medication, you should not be driving. But you could make an argument that if somebody had surgery on the left leg and you're driving an automatic and you can control that vehicle just fine, that's a decision that you sort of have to make on your own. There's no law against it, but there can be liability issues. The other thing you have to consider too is, we don't recommend after surgery like that taking any long trips in the car anyway, because you're increasing your blood clot risk and potential for getting a DVT. So have that conversation with your physician, and they'll kind of give you guidance on it, but they probably won't give you permission.
Very good. Next question is, when you speak of a needle introducing infection, is it apparent immediately or something that is latent and flares up at a different time? If so, what period of time and in general would this be problematic?
Yeah, most people, you're not going to see an infection in the clinic right after you do the injection. And again, this is something that is very, very, very uncommon. And I'm simply saying that usually what the literature is discussing and what we talked about was that the number of injections that have been performed prior to the knee replacement can increase the risk of a post-operative infection. And it's multifactorial. It's how often did you inhibit the body's ability to form an inflammatory response to fight infection with multiple cortisone injections? And is any bacteria, even a microscopic amount, introduced with each injection? Not enough to cause an infection in a knee, but maybe enough when you put inert objects like metal and plastic into a knee that don't have a blood supply, and if bacteria sticks to that, your body can't fight it. So
next question is collagen. Is it helpful in the supplemental form?
It's another one where it's very anecdotal. You're not going to grow new cartilage or anything like that. It's a matter of, can it strengthen it? So you look at the interplay between, is there any downside to it versus is there potentially upside? And if it works for you, great.
Great. Last two questions. Can a person run or hike after knee replacement surgery?
Well, I think we already touched on the running part. It's really discouraged. And I have seen patients in my practice do it and did well for about 3 months after surgery. And then all of a sudden they were having pain and swelling in their knee. And I asked them if they'd started running again. The answer was no. But then the physical therapist said, well, yeah, they told me they are. And that knee has since been replaced. So you really shouldn't run on knee replacements. And what was the other part of that, Sean?
Run or hike.
Oh yeah, hiking you can do. You know, I don't know that I would necessarily recommend that you try to go do Shiloh, but you know, again, hikes that are maybe a little bit harder, the terrain is steep and maybe not as solid, and where you're really coming down with each step and pounding on it, that may not be such a good idea. But there's a lot of people that have their knee replacements because that's exactly what they wanted to get back to doing, and there's no problem.
Great. This is looks like the last question for now. Are you accepting new patients? And if so, do I need a referral from a primary care doctor?
The answer is yes. I'm definitely accepting new patients. And if you're Medicare, you do not need a referral. Some of your insurances don't need referral. You kind of have to talk to your insurance carrier and ask them whether your insurance requires a referral or not. Most of the HMOs, you will need a referral from your primary care provider, and most of the PPOs, you do not.
Great. So I think that concludes what we've got. Thank you, Dr. McDermott.